Good morning, everyone. Thank you so much for joining us today. We are so excited to have you all here for our second installment of the Unchained California Learning webinar series. We have a great presentation for everyone today, and I'm really excited to spend the next hour together. My name is Leslie Alfaro, and I'm a program manager here with the Unchained California team. I invite all of you, as you're trickling in, to write in the chat who you are, where you're from, where you work. We want to know who's here today. Just make sure that when you're typing out that chat message, you send it to everyone so that all of our audience can see and not just us in the background here. Just as a super short overview of where the campaign is. As most of you know, we are partnership with Shatterproof and DHCS working on a 10-month educational campaign to reduce stigma around substance use disorder. We officially launched in March, and we're really excited to continue to bring stories of Californians across the state who've been affected by substance use disorder. We have up to 43 partners now. So if you don't see your name in one of these tiny font names here and you want to be a part of it, we encourage you to email us. Saskia and I are always more than happy to talk to people about what becoming a partner means. We want to hear, what you're working on. We want to know what's happening across the state. So please feel free to reach out. We are always looking for more partners to continue to spread the word. I'm also really excited to share that we officially have our 10 members for our Community Impact Committee. Our CIC is the advisory board for our work, and we're really excited to work with them. Just to continue to improve the campaign, hear all of their names. Hopefully very soon we'll have all of their bios and headshots up on our website, so you'll be able to go and see who is working with us. And then as a story countdown, we are update of number. We have 8 people who have shared their stories. We currently have 2 of them posted, but are working with our digital team to continue to bring those stories to you. Again, we have so many great stories that we've collected over the past couple of months, and we've been trying to, pilot new formats for how to bring those stories out to everybody in a way that's going to be the most impactful. So I can't wait for you guys to see all of those. As always, if you know someone who wants to share their story, whether it's you, whether it's someone you work with, it's someone that you think might be interested, we'd love to talk to them. Same email, unshamedca@shatterproof.org. We set up a short call, takes about 10 to 15 minutes, and we just answer all the questions that someone has. We walk someone through the process so they know what it looks like to share their story. And of course, this is a conversation. At no point is there a commitment. So set up a call. We'd love to talk to you, to someone that you know, about what it means to share your story. We want to get as many stories from across the state as possible. And I know we have not even finished this webinar, but are you registered for the next webinar? Our next one is going to be on June 15th, and it's going to be on the science of addiction with Dr. Brian Hurley. I'm just very excited today. But we can't wait to bring that to you guys. And we do have this series ongoing. It is the 3rd Thursday of the month. So if you visit tinyurl.com/unshamedcalifornia, you'll be able to register for as many of those webinars as you want. Overall housekeeping, this webinar will be recorded and be made available on the Unshamed California website. We invite everyone to continue to use the chat. If you have any questions, please use the Q&A. We will be monitoring those behind the scenes as well. And we will have a Q&A section with Dr. Barry Jacobs at the end as well. So encourage you to continue to add those through. Lastly, we do have Spanish interpreters available. So you can go through at the bottom, select that interpretation, change the language. So that is available for everybody. Thank you guys again for taking the time to join us today. If you do have other questions, feel free to email me. I am available. And with that, I am so excited to have Dr. Barry Jacobs with us today. We are really excited that he was able to join us. He is a Philadelphia area-based clinical psychologist, author, and former family medicine residency program faculty member who's now a principal for Health Management Associates, a national healthcare and research consulting firm. He has treated individuals with substance use disorder for over 30 years and currently provides consultation with substance use disorder treatment providers in California and other states on increasing community engagement and implementing evidence-based trauma-informed practices. Please help me in welcoming Dr. Barry Jacobs today. Over to you, Dr. Barry.
Thank you so much, Leslie, and good morning, everyone. It's really a pleasure to be here with you. I appreciate your putting your names in the chat. Gives me an idea of who's here today. And it looks like we have many folks doing really good work as providers. I'm going to share my my PowerPoint, and we can get going. One of the things that you'll notice about me as we go through this is I love interaction, and so the more you bring up your own thoughts and comments, the better I like it, because then we have more of a dialogue, and it's less me holding forth and just being a lecturer. I would much prefer that this be a conversation. So the topic for today is overcoming stigma, specifically in maternal opioid use disorder. But as you'll see, a lot of what we're going to talk about today really applies more broadly than that. Certainly, pregnant women face some of the worst stigma when it comes to their use of opioids and other substances, and this is stigma that, as we'll discuss, occurs on multiple levels. So here are today's learning objectives. We want to talk a little bit about barriers to both let me go back, opioid patient and provider engagement because of three types of stigma, and we're going to define them much more specifically in a moment. Self-stigma, social stigma, and structural stigma. We're going to talk a little bit about how stigma influences individuals' treatment choices, and how those treatment choices and stigma impact them while pregnant and afterwards. And then we're going to talk a little bit about how, as providers in particular, by increasing our empathy in overcoming our stigma, we can increase our engagement for individuals, help them engage in medication-assisted treatment and other treatments for opioid use disorder. So I hope this is what you have in mind for today. And so let me forge ahead. Maya Angelou, the former poet laureate in the United States, is dead now about 8 or 9 years. I'm afraid some young people are not getting to know her, but she was really a treasure through her life. As a poet, she wrote a very famous memoir that you may have read in high school called "I Know Why the Caged Bird Sings." But I love this quote by her, and I'll explain why. I have it up here in just a moment, but the quote is, "I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel." And I think, especially for people who feel very stigmatized by their use of opioids, the way we treat them matters enormously to how they feel about themselves, but also in terms of their ability to enter recovery treatment and try to kick drugs. I mean, it's something that the way we treat people is more important than any evidence-based treatment that exists, in my opinion. So let's start off with a fictional case. So this is just a photograph that I found on the internet. And I have made up an entire story about this photograph. So this fictional person is called Sandra. She's 18 years old. She comes from a very close church-going family. And unfortunately, while she was in high school, like many teenagers, unfortunately, she began partying with different drugs, and including with Percocet and Vicodin. And she ultimately became dependent on these medications. At the same time, she's now at this point in time pregnant, and she has a lot of shame about her drug use and her pregnancy. And though she knows that it's important to get good prenatal care in order to make sure that her baby is healthy, she doesn't show up at the local gynecology clinic until she's 30 weeks gestation. So when she gets to the clinic, she's met by a doctor who gives her a look as if he's judging her. And Sandra, unfortunately, believes that he's critical of her because she's coming to the clinic so late at 33 weeks. And, you know, if she revealed in her medical history that she is using substances, or if they do blood work, then he'll be even more critical. And then she's also afraid that, particularly if he finds out about her drug use, that he's going to report her to Child Protective Services, and that what her concern is that when the baby is born, the baby will be taken from her and placed in foster care. So this again is a fictional case, maybe one similar to cases that you've had, maybe not, but I'm wondering if you put yourself in her shoes, what do you think she might be feeling as she goes to the gyne clinic, kind of under the judgmental gaze of this doctor? And then how do you think these feelings are going to affect what choices she makes for prenatal care, for substance use care? How do you think the treatment by the provider is going to impact her? So we're a fairly small group today. You're welcome to put something in the chat. You are welcome to unmute and just share an answer. But I'd love to hear your thoughts about this. So Sean says fear and embarrassment, shame and guilt. Thank you, Sean. I think that's right. I mean, you know, all those things. I mean, there's certainly shame and maybe guilt, and certainly there's going to be fear. And Elizabeth says absolutely fear. Other thoughts? Yeah, let me get to the second part of the question then. So if she's feeling fear, embarrassment, shame, and guilt, how do you think this is going to affect the likelihood of her coming back to this clinic and having further prenatal care? What do you think is going to, how do you think she's going to react to this? And as George just says, she may never come back. And Melissa says the same thing. She would likely not return. And I worked in family medicine for 24 years. And even though I'm a psychologist, I was a faculty member in the family medicine residency program. And this, we saw many times folks that wouldn't return to us or wouldn't return to the gyne clinic in our health system because they presumably felt judged by the providers. And so that has ramifications for them. It has ramifications for their babies. Elizabeth says as well, likely not to return. So I think we know here that we're talking about stigma. So we're talking about, in this particular story, we're talking about a number of different types of stigma that we'll get to in a moment, but let's just start off with the basic definition of, so how do you define stigma? I mean, we have this strange picture in the background is a stigma of a plant, but that's not what we're talking about here. It's a stigma of a flower, I should say. But so how do we understand stigma in the substance use disorder field? Any thoughts? Okay. So feel free to put something in the chat. I'm going to go ahead. Here's, let me read the chat before I read this. Shunned and disgraced. Those are two very powerful words, Sean. But I think that's what we would probably call social stigma, where someone is feeling that people around them are shunning them and disgracing them. I see the dean says things that are unwilling to face, that they feel ashamed of. Elizabeth says less than. Christy says she likely would not seek any further care, and kind of responding to the first question. So I think that all these are right, and they're different. You can already hear in the answers in the chat box that there are different aspects of stigma, whether someone feels stigma toward themselves or they're feeling stigma coming from outside themselves, from a doctor or from a family member. And so we're going to talk about that in much more detail. So a very formal definition of stigma would be negative thoughts attributed to mental health or substance use leading to a negative behavior. And that means, people who feel that either they themselves are feeling ashamed, or they're feeling other people are shaming them, and then that then leads to perhaps a lack of engagement with treatment, and that would be the negative behavior in this case. A little bit more poetic definition of stigma is stigma is a prejudice endorsed by many, a way of creating the pretense of a them to a pretense of an us. It is the tool of bullies, as are most such epithets. And this was this very poetic phrase was in a blog response by someone named Harold Mayo. But it basically is saying this is the kind of prejudice that people have to separate others from them, to create this pretense of an us and them, and consequently to look down on those folks that are them, folks like Sandra, who are pregnant and are using substances. So let's put this in a context, a larger context. And so I'm very interested in kind of evolutionary psychology, and for instance, I think that a lot of human behavior is kind of based on what has survival value, what has allowed us to survive as a species over many thousands, hundreds of thousands of years. And I start with a basic premise, and that is one of the main things that human beings do, and do it in very rapid fashion, is they make distinctions. So they distinguish between what is a safe situation and what is a dangerous situation. What is good food to eat? What is bad food to eat? What is comfortable? What is uncomfortable? And we make distinctions like that very, very quickly. And those distinctions, as I said, have survival value. They helped us avoid danger, live long enough to pass on our genes to the next generation, and voila, here we are all these years later. But a lot of the capacity for making distinctions in our environment has been hardwired into the way our brains work. But where that leads, that's just a starting point for a whole series of kind of generalizations. So when for instance, when we're thinking about what is a safe place and what is a dangerous place, we may categorize, well, maybe a certain type of neighborhood will consider dangerous, or maybe certain type of people will consider dangerous. And so we're beginning to move from that basic distinction to a generalization. And then if we may say that if we're generalizing about the certain type of people as being dangerous, then maybe we begin to label them with a kind of stereotype that these are people who are dangerous. And now, not only are they dangerous, but I have a negative judgment about them. And then that very quickly leads to prejudice. I have a certain prejudice against these type of people because of all the negative judgments I have about them. And then prejudice leads to action. And the action is I discriminate against those people. If I see those people on the street, I not only do I move away from them, but maybe I make a face at them. If I'm in a position of being able to choose for a job, one person over the other, maybe I'll choose someone from a group that I believe is a good group rather than a group that I think is a bad group. And then if I'm in a position as someone who's an employer, for instance, where I have power, then my discrimination becomes oppression. I'm making distinctions on the basis in creating stereotypes, developing prejudices, and discriminating against people on the basis of judgments that are not often based on very much. And so this is all coming from a psychologist named Dr. Harrell. But I think it's an interesting set of attitudes that start from something which I think is kind of inborn in all human beings. We also know that stigma kind of comes from and affects all other parts of life. You know, stigma comes from our families. It comes from the cultures and society in which we grow up. And we know that there's a connection between stigma and economy, that typically when the economy is bad, when lots of people are out of work, then people tend to be, not have more discriminatory behavior towards others. And we know that within the healthcare sphere in general, there's a lot of stigma towards patients, but there are also stigma from patients towards certain type of providers. They don't want to see an African-American provider. They only want to see a white provider. I used to hear that not infrequently in the family medicine center where I worked. So stigma has a lot of impact on really most facets of our lives, I would think. So we know that there's an opioid crisis going on. It's been going on a long time. I just saw the figures that came out this morning about the overdoses, opioid overdoses in 2022. And, so this is always in the news. And there are lots of folks that have feelings about this. What are some examples of bias that you have heard in the opioid crisis? And I'll as you're thinking about that, I'll just share one with you that I was telling Leslie about that occurred to me yesterday. I was giving a presentation, and there was somebody there from a family medicine office, an advanced nurse practitioner, who was saying, they provide Suboxone in that family medicine office, but that the front desk staff and the office manager have so much stigma towards people who come in for buprenorphine that those people are very uncomfortable coming in, and therefore it actually is an impediment to their getting what could very well be life-saving treatment for them. And so that seems to me to be a very serious provider stigma, and that's not even on the part of the prescribers, that's on the part of the support staff. That the family medicine office there is not a comfortable place for people to come with Suboxone, because they can feel the negativity coming from the receptionist and other staff members. So that's one example. Do other folks have examples of that? Anyone? Saskia says, whoops, they go up. Saskia says, I spoke with an SSP recently that shared people who use drugs also have bias internally based on type of substance used. Interesting, Saskia. I'd love to hear more about that. And Leslie said some that we have heard, that there are certain people who have OUD. Certain people sounds very off-putting. It sounds like we're putting them in that other category. George says, providers feel that patient is weak. Why don't they just stop using? I think that term weak is we use it in a very pejorative way, that somebody lacks character, that they lack will, and therefore they're giving in to their addiction. And so those are all, I think, very good examples of bias that comes up. Okay. So we've already started getting into this, but let's unpack this more. So there are 3 types of stigma that we're going to discuss. Self-stigma. Maybe Saskia was talking a little bit about a type of self-stigma. There's social stigma, and I'm lumping into that provider stigma. And then there's structural or systemic stigma, and that includes things like societal views or institutional policies. We're talking about very, very large system stigma. And I'll share more about that in a moment. So here is a very psychological, or actually a psychiatric definition of self-stigma: internalizing and endorsing negative stereotypes of the self. For instance, I am dangerous. And prejudice, for instance, I am afraid of myself, results in self-discrimination. For instance, self-imposed isolation, low self-esteem, and poor self-efficacy. Self-discrimination, particularly in the form of self-isolation, has many pernicious effects, leading to decreased healthcare service use, poor health outcomes, and poor quality of life. In other words, when people feel ashamed of their drug use, that in and of itself can prevent them from seeking help. Not only help with their drug use, but help with any health problem. It could make them pull back from social circles. It could isolate them because they carry this fear that others are judging them, and they judge themselves so harshly. Which is really an enormous problem, I think, and one of the biggest barriers to effective substance use disorder treatment. And we know that once stigmatized, it's very hard, even years later, for people to rid themselves of some of that self-stigma. So here's another quote: drug addiction stigma continues to impact the lives of people with a history of drug addiction, even after they have enrolled in MAT, is essentially the same thing. The stigmatizing mark of drug addiction lingers after the behavior of drug use has ended. So even when someone has really taken that important step of saying, yes, I'm the 12-step program. That's step one. Right? I'm helpless before my addiction. I need to, there's something I need to raise my hand and say I need help with. That even when they do that, even when they're taking a Suboxone or methadone or Vivitrol, so they're doing what they're supposed to do, and they're going to counseling, and they're working the program, and they're working their recovery. Even then, many folks still have this feeling of stigma and feeling shame that somehow that they have ruined their lives, or that they're inadequate, they're weak, they're deficient. I see a comment here. George says often the opioid use disorder, alcohol use disorder diagnosis remains in the patient's problems list for years after an encounter. And what you're referring to, George, is that in a medical chart, at the front of the chart, generally there's a medication list and then there's a problem list. And I can verify that what you said is true, that what is put on the problem list in a medical office tends to stay there forever. So, I mean, it could be something fairly benign. If you had a sinus infection once upon a time, and someone puts sinus infection on your problem list, you may not have had another sinus infection for 5 years, but there it is, the sinus infection. And the same thing is true for opioid use disorder and alcohol use disorder. Those things seem to take on a life that never ends until one day the provider takes the time to clean up the problem list and clean up the medication list and remove things. But it doesn't happen often. The United Hospital Fund of New York a couple of years ago did a really excellent report. It's called "The Ripple Effect: The Impact of the Opioid Epidemic on Children and Families." And so here's a quote from that excellent report. This is from a physician who said, the two most common questions women with OUD ask during prenatal care are, will my baby be okay, and will my baby be taken away? And so those questions are really kind of burning questions for these women, that it really feels as if they're already feeling guilty, that they're harming their babies, and they're really worried that they're going to be punished by having the baby taken from them. And here, this too kind of reflects a very harsh self-stigma. I would hope that their babies would be okay. And generally speaking, if they're on Suboxone, for instance, methadone, their baby is going to be okay. Will a baby be taken away? It really depends on the jurisdiction, unfortunately. So back to Sandra. We know that she has a lot of self-stigma and very harsh self-judgment. And as a consequence of her self-judgment, she's got low self-esteem, low self-efficacy, and she's also feeling helpless and hopeless. And we know that when people feel helpless and hopeless, they're very often depressed. And so she is struggling, and she wants to do the right thing by her baby, and she probably wants to stop taking Percocet and Vicodin one day. But then when she goes to the gyne clinic, rather than feeling like she's being supported in reaching out for care, finally, she is feeling judged, and that just reinforces her self-stigma. So how do we reduce self-stigma? So there's a lot that's been written over the years in the psychological literature about this. And truthfully, there isn't one evidence-based treatment. There are just a number of ideas that people have. But the most important thing is to create a new basis for a more positive view of oneself, a more positive self-appraisal. And so I know last presentation in this series was about language, and not having people call themselves addicts or junkies or any of that really terrible language like that. And by the same token here, we don't want people to let their SUD disease define them, because that may be some of what they're struggling with, but that is not who they are. And so we're trying to find, with all the things I'm going to recommend, we're trying to find ways for them to feel that they're still a good person, that their lives are still meaningful, that they still make positive contributions to the world. And even if they're a pregnant woman with opioid use disorder, it does not mean that they are consigned to negative judgment for the rest of their lives. And the three ways I'd like to just mention here for reducing self-stigma is one, vocational therapy, and I'm not going to talk much about that. I mean, basically, what does this mean? It means that one of the best ways to make people feel better about themselves is get them a job. And when they work, especially when they feel like they're working in a productive capacity and that they're helping other people, regardless of whatever mental health or substance use disorder problems they have, people feel better about themselves. And that becomes that job, that feeling of making a difference to others becomes a new basis for more positive self-appraisal. The other two things I'm going to mention here are two types of psychotherapy. One is called narrative therapy, and the other is called acceptance and commitment therapy, most often referred to as ACT. So a little bit about narrative therapy. So the gentleman on the screen here is unfortunately deceased family therapist, but a really interesting guy named Michael White, an Australian who in the 1990s did a lot of writing, a lot of presenting about narrative therapy. And his basic thesis was that all of us, all human beings, we have certain stories we tell ourselves about ourselves. So those are the narratives. And that some of those narratives can be quite optimistic, quite positive, quite uplifting. They can be about how we overcame difficulties, how we, took some of the circumstances of our life and made good on them. And some of them can be very negative. Some of the stories we tell ourselves about ourselves could be how we had a good upbringing and we went on the wrong path and we made the wrong choices and we ruined our life and there's nothing that can be done to help us. And the whole thrust of narrative therapy is to help people understand that some of the ways they understand themselves have been externally shaped, that they grew up in an environment perhaps where on the basis of their race, on the basis of their culture, the basis of their socioeconomic status, they may have just been discriminated against. Maybe they've been traumatized by sexual trauma, physical trauma in their lives. And so we're trying to help people understand that the stories that they tell themselves about themselves are rooted in societal circumstances that may not be under their control. But what's within their control is that they can rewrite those stories that they tell themselves about themselves, and they can look for those positive aspects of it that will help them feel better about themselves. And that one of the techniques that Michael White used and is probably most famous for is called the externalizing technique. And that is, we actually, with any problem, and we'll use opioid use disorder here, we don't say that we don't say that the opioid use disorder is me. I'm opioid use disorder. We never say that, but we also don't say I am somebody with opioid use disorder. You externalize it even further. I live in adjacent to opioid use disorder. Opioid use disorder is my enemy, is like this force that I have to battle against all the time, but it's not internal to me, it's external to me. And I can even name it. I'm going to call my opioid use disorder, I don't know, Bob. And I spend a lot of my life fighting Bob, and here's how I do it. So believe it or not, it sounds contrived, but there's something in that externalizing a problem so that people don't identify so closely with it, that helps them feel that who they are isn't the problem and helps them feel better about themselves. So that's one technique. The other technique is called ACT, acceptance and commitment therapy. It's a form of cognitive behavioral therapy that was developed by a psychologist by the name of Stephen Hayes. And basically, to me, what this is a combination of is the serenity prayer, that is accepting the things that cannot change, and using mindfulness techniques like meditation, yoga, breathing exercises, body scan, things like that, in order to help us be less reactive to some of the things that have happened in our lives, but to learn to accept ourselves better. And again, this can be a very powerful technique for helping people feel better about themselves. So I already said that a lot of self-stigma is based on what messages we get externally that we wind up internalizing. But if a lot of the problem is coming from external forces, we really need to think about social stigma. So what is social stigma? And it's the disapproval of a person based on perceivable social circumstances that serve to distinguish them from other members of a society. And that basically is, we make those distinctions, we develop categories about certain people who have those distinctions, and we develop stereotypes, all things we went through before. We develop prejudicial attitudes, we have discriminatory actions against them. All of that is part of social stigma. And social stigma is not just something that we suffer in our families or with health providers, but folks suffer social stigma at the hands of everybody, of neighbors, of people in your church, of educators, of employers. And as I mentioned, social stigma, the messages, those negative messages of maybe being in an ostracized group or being in a group that's somehow looked down upon, that social stigma feeds self-stigma. So when we think specifically about the type of stigma that providers have, for instance, this imaginary doctor from the gyne clinic, why do providers have stigma towards certain types of patients? We would hope that there are professionals, that they're trained to not stigmatize certain individuals. And so some of it has to do with their personal life experiences. It may be that they grew up in a home where certain groups were discriminated against, and therefore they internalize some of that discriminatory behavior and still practice it. It may come from some of their professional experiences too. For instance, I mentioned I worked in family medicine for a long time, and if a physician felt that someone kind of quote unquote ripped them off, meaning convinced them that they had chronic pain and they needed an opioid, and then found out later that that person was selling that opioid or abusing it in some way, that physician would be very angry that their license, that their livelihood, their training was being used for bad purposes, and they would then develop a stigma towards anybody who came in who might have chronic pain. Providers who have stigma are also often ones who have or have been burnt out. They're worn out. They're stressed out. And being worn out, burnt out, stressed out does not bring out the best in anybody, including physicians, including mental health providers. So what happens, as we saw in the case of Sandra, is when providers have stigmatizing attitudes and behaviors, it leads to a lack of rapport with the patient. And actually, even worse than that, it leads to kind of alienating behaviors. It leads to Sandra feeling like this doctor's staring at her in negative judgment. And it often leads, I'm afraid to say, to the doctors not doing what it is that they're supposed to do to help a patient. And so not only does Sandra not want to come back, but maybe this doctor didn't even give her all the prenatal care that he could have or should have at the time that she came in, because he just wanted to get her out of the clinic. So it absolutely breaks down the efficacy of healthcare interventions, healthcare visits. So there are many problems with what I just described. Certainly, one of them is we miss an opportunity for anybody in the healthcare to make a difference for somebody who is suffering from substance use disorder. So, as with this quote, it is critical for clinicians to address drug addiction stigma from a variety of sources within treatment settings to bolster the mental health and recovery efforts of patients. When a pregnant woman goes to a gynecologist, pregnant woman with OUD goes to a gynecologist, that gynecologist, in the way that person, that professional behaves, the way they respond, could make it better or worse for the pregnant woman, and in fact could make it very difficult for her to come back if she's feeling judged. So I'm going to skip this next question here. I'm sure you have examples of social stigma toward pregnant women with OUD, and if you do, you can certainly put them in the chat. But I want to go forward. So how do we reduce social stigma? And I think a lot of it comes down to our training, our socialization as professionals. There are specific paper and pencil tests that can be administered. Actually, probably in this day and age, it's more like computer-based tests, but things like the implicit associations test or the stigma self-assessments, where we can have people do their own self-assessment about whether in fact they have social stigma towards certain types of patients. And then, as part of their educational experiences, as part of their ongoing professional experiences, for them to meet with folks that they may have stigmatizing attitudes towards, but under the right conditions. So, for instance, if we had a way for Sandra and this gynecologist to not just meet in the gynecologist's office, but to meet somewhere else, where the gynecologist would hear a little bit about Sandra's life, how she got to this place, to hear about her fears and embarrassment and shame, then the hope is that gynecologists would then have more empathy towards her and not only be softer to her, but be softer toward any 18-year-old woman who's pregnant with OUD who comes into that gyne clinic. And then we mentioned using alternative terminology. And I know you guys, if you were at the last webinar, you heard a lot about that. I'm not going to say a lot about empathy other than to say that, it's just as Maya Angelou said, the way we make people feel is what they don't forget. And if we put ourselves in their shoes, or perspective taking, if we are non-judgmental, if we're recognizing what they are feeling, and we communicate to them that not only have we heard them and understand them, but we care about them, that goes a long way to making anybody feel better about themselves, and makes it more likely that they're going to return for additional treatment. And if we're not empathic, if we're unempathic, then the opposite happens, and not coming back. And again, specifically talking about providers, a lot of it is that education, training, and experience. but there also have to be leadership that has to be part of their where they work, that really insists that they behave in a respectful way, in a person-centered and trauma-informed way with everybody who comes to see them for services. I'm going to skip this particular slide because I think we've just gone over most of these things. And I'm going to talk a little bit about the last or third form of stigma called structural stigma. And I put this this very kind of jarring picture on the slide of going back to the Jim Crow days when throughout large parts of this country, there were services for white people and services for Black people, including different water fountains. And this would be a type of structural stigma, type of structural kind of system-wide, large system-wide discrimination that pervaded every aspect of society. That said, we live in states, we live in counties, we work for health systems, we have there, we may be part of larger institutions where there may be kind of built into the policies and procedures certain stigma towards certain groups. And then we really have to be be aware of some of the structural stigma that exists within the institutional context that we work in, and then we have to kind of really ferret out those stigmatizing practices and address them. I mean, really, just the way the civil rights movement addressed it, with a lot of protest and a lot of advocacy in order to really integrate equity into our institutional policies. And so I'll give you one example of this, and then I want to make sure we have enough time for questions. But an example of this is I know there are hospitals that if a pregnant woman came in and she tested positive for opioid, the hospital, after the baby was born, would not let the mother breastfeed because of some fear that the mother would be passing on to the baby after the baby's birth, something harmful, because the mother has substances in her blood. I mean, there's no scientific basis for doing that. That's a kind of punishing behavior toward a mother with opioid use. It's not. There's no scientific basis for protecting a baby in that instance. So that, to me, is a kind of structural stigmatizing policy that causes harm, makes women in this situation feel much worse. Does anybody else have other things that you've seen in our society as a whole, in the health systems, in other institutions, where there are policies that seem almost kind of geared towards making women with opioid disorder, or anybody with opioid use disorder, feel worse? I see something in the chat. And Dean says, I had a rental property that wanted to limit our client on the property at specific times. You say limit our clients, so they didn't. Let me just I'm going to kind of guess, Dean, and you're going to have to tell me whether I'm right or wrong, that they were afraid if folks came to you for substance use disorder treatment, maybe they came to you for medication assisted treatment, that would somehow make a bad impression on the neighbors near the property, and the owner didn't want that. So they would okay, correct. Okay. So I'll give you a very similar example, or actually one that I think is even worse. So I worked for a health system for many years, and many of the physicians in the health system decided that they were going to get X waivered. You don't need an X waiver anymore to be able to prescribe Suboxone, but at that time you did. And so like 5 or 6 of them went and did the training so that they can be X waivered, and they were all ready for us to announce to the community that we were now going to be prescribing Suboxone. And the health system, let's just say the owner of the health system, said, nope, you're not allowed to do that. We're not going to allow you to do that because we're afraid of some sort of backlash from the community, that they're going to be upset that we're bringing people with drugs problems into the neighborhood. And so even though these physicians were trained, wanted to provide Suboxone, it took about 2 years before the health system changed its policy, and which I found to be completely outrageous, considering that there's a large health system which had a behavioral health unit in a certain community, one part of the health system, where both methadone and Suboxone was prescribed, but they didn't want Suboxone prescribed in a family medicine office for fear that it would alienate kind of your general medical patient. So I'm going to any other examples of this? So I'm going to stop sharing and just give us an opportunity to just kind of talk together. And I know, I have a question actually for Saskia, because I heard, Saskia, you say that that this kind of stigma about people using certain substances, and I kind of wanted to get more of a greater understanding of what you're referring to.
Oh man, I messed up the spotlight. Let me add you in. So I spoke with an SSP recently that said that internally, I meant within the community of people who are using substances and receiving supports from their SSP, that there is stigma about the types of substances that are being used and how those substances are being consumed. So we didn't get into too much detail, but kind of thinking about, there's these layers, right? And we see that as well in conversations around AUD versus OUD. I spoke with someone recently who said that they at first would talk about themselves being in recovery really generally, so that people would just assume that it was alcohol use disorder instead of opioid use disorder. So that was a conversation that had come up that was really interesting.
Yeah, I appreciate you sharing that. And I mean, to me, again, it just shows that human beings are very good at making distinctions and very good at making kind of us versus them, unfortunately. So, I mean, I've heard the story for years that if you were someone with OUD and you show up at an Alcoholics Anonymous meeting, then you were going to be they were going to make you leave, right? Because you're in the wrong place, even though the 12-step program is virtually the same from from NA to OA to AA, but it's like those folks that were using, fentanyl or heroin were not as good as the folks who were using alcohol. So yes, that goes on, and that too would add to self-stigma for sure.
I think we see that with MOUD as well, right? There's stigma within the recovery community around using medication for opioid use disorder as a treatment tool, and we've tried to dig into that too, to understand that and understand how to reach those populations. And the response being, from some people, that this is the way that they recovered. They're, whether it was a 12-step program or kind of whatever tool that was for them. And so that is the right way to recover. And there being right and wrong ways, and kind of creating that binary around it as well.
I absolutely agree with you, and I think that's tragic, because you need to use all ways to help every individual, and not every individual is going to be responsive to every treatment or any specific treatment we think is best for them. Other questions or comments about this topic, or maybe specifically for pregnant women with OUD? What have you seen? What has worked for you? What do you think about these thoughts about, especially for decreasing self-stigma, for narrative therapy or for acceptance and commitment therapy?
I have a question for you here. One of the things that we hear a lot, especially when it's women who are parents, is that there's sort of an additional expectation that they're supposed to be very maternal, very caring. And if they have OUD, that somehow cancels that out. So there's increased expectation and therefore increased stigma. How do you think that we can better involve and educate communities to promote empathy, especially for people who are parents who have OUD?
So, I mean, I would think in this instance, you have folks in the community who are assuming that if you have OUD, you're a weak and selfish person, and you don't really care about your children, and you only care about getting drugs for yourself, and you're going to neglect them, and pity those kids. And does that happen sometimes? Yes. But does it happen in the majority of the time? I would doubt it. And so how to demonstrate to the community as a whole that there are very good parents, and there are actually very good parents making very good livings and supporting their children in wonderful ways, and those parents happen to be on Suboxone, and that having a substance use disorder of any kind or an opioid use disorder doesn't mean that you love your children less, and doesn't mean that you neglect them. And so it might mean someone raising their hand and saying, I'm a parent, you know me as part of the community, you don't know I use Suboxone, but here I do, because it helps me, actually helps me be a better parent than I would be otherwise.
Yeah, I think that's great, and really kind of the core of what we are trying to do by sharing stories, right? Whether it's parents or you have a loved one or whatever it looks like, sharing those stories to show that it can be anybody, and OUD, SUD can affect anybody. I have another question here for you. How can we foster collaboration between healthcare providers, social service agencies, and community organizations to create a more comprehensive support network for parents with OUD and reduce that impact the stigma has?
I mean, Leslie, that's a big question, and I'll answer it. I'll give you a short answer. But I mean, I think we have to all be joined in the goal of beating back this crisis, this opioid crisis that is still rampant, and we only do that by joining forces in every way with all the folks that make a difference. And I think I am hoping that particularly for healthcare professionals who are younger, that have trained in the last 10 years, that we're at a time when this crisis has been kind of more front and center, that they have better training, that they have better attitudes, that they see their involvement in this as essential, and that there's much better appreciation within healthcare of how important social determinants of health are, including transportation and housing and food. And that so we embrace all caring professionals have to work in conjunction with parents to help them do as well as they possibly can. And that is only through these community-wide efforts that we can really kind of keep the opioid crisis from causing further damage. And so that's a hope. How to make that happen? It's through education, through training, through building collaboratives and giving people from these different silos experience of working together, of bringing people with lived experience into healthcare, bringing people with lived experience into the boards of directors of nonprofit agencies. I mean, all those things are crucial to bring everybody's voice to the table, and that's what's necessary to make a difference.
You mentioned it a little bit earlier, but the opioid crisis comes up so often, and we see it on the news, and it's this big thing. It's very scary, and it continues to grow and get worse. But what gives you hope? Like what's going well, and what's something that sort of gives you that hopeful light at the end of the tunnel?
I mean, I think we have much greater awareness of not just the dangers of xylazine and fentanyl and all the other substances that are out there. We have much more awareness of the benefits of MOUD. We have much more awareness that often that there's of trauma's impact on individuals, and maybe to a disproportionate degree on individuals with substance use disorder. So I see we're at time, and I see a thank you already going out there. But so I want to say thank you all for your participation and for listening, and thank you, Leslie, and to Unchained California and to Saskia for having me here today.
Yes, thank you so much, Dr. Berry. We will be sharing both the recording and the slides with everyone. So if you do have any other questions, please email them and we will make sure that they get to Dr. Berry. Thank you, everyone. This was a great conversation. I really want to send out my thank you for you guys spending the time with us, and look forward to more conversations.